Hello, everybody. Welcome to another episode of 7 Minutes Medicine. We're going to talk about hypocalcemia. The definition of hypocalcemia is the calcium less than 8.8 milligram per deciliter. This is the total calcium, or the ionized calcium less than 4.7 milligram per deciliter. And you might find this a little bit different from place to place. Let's talk about the history and physical. So when there's acute drop of calcium, you might have two main symptoms. First, you might have the neuromuscular irritability. The patient may come with paresthesia, muscle twitching, seizure, laryngospasm, bronchospasm, and also there's two interesting signs. First, the Trousseau sign, where there is carpopedal spasm after inflating the blood pressure cuff above the patient's systolic blood pressure, and shaphistic sign when there's a twitching in the cheek after tapping. And the other really important complication of hypocalcemia is the cardiovascular, the prolonged QT interval, which can result in severe arrhythmia. But when there's a chronic change in the calcium, we expect some eye changes like dry skin and cataract, and also some neurological changes like Parkinsonism and dementia. So right now we're going to talk about the diagnostic approach for hypocalcemia. So first step in diagnosing hypocalcemia is to confirm that there is low calcium. And to do that, first you should correct the total calcium value that you got from the lab. So technically you should correct for albumin. The lower the albumin, the higher the real total calcium. So we use this equation, and we can plug 4 instead of the normal albumin and calculate our total calcium. Then after we confirm that there is hypocalcemia, we can check the ionized calcium just for further confirmation. And then we start our diagnostic approach by assessing the PTH. The PTH, if it's elevated, then this is PTH independent, because if the PTH is elevated and the patient still have low calcium, that tells us that there is something independent from parathyroid gland affecting the calcium. And that might be the low vitamin D, so you check the vitamin D level, 25 normally, and this is nutritional vitamin D deficiency. And if the patient has high phosphorus, then you start to think about a chronic kidney disease if there's affecting the kidney function. And you confirm that low vitamin 125, which is the form that is activated in the kidney. And if it's low, then you know that this is 100% related to that chronic kidney disease. There is also some genetic disorders where the phosphate is high, the pH is high, and there's normal renal function, there's normal vitamin D, which is called PTH resistant, and we see it more in pediatrics. Let's say that the PTH was kind of like normal or low, which is interesting, because if the calcium is low, the PTH, the normal physiologic response should be PTH high. So the PTH is low, that tells us there's a problem with the PTH secretion. So first we have to check magnesium, because magnesium is taking part in the production of PTH. So if it's low, then you just fix the magnesium and everything will be taken care of. If it's still normal, then you have to dig more. Some people would have already hypoparathyroidism, and you would know this from the history, like a surgical history, or they have autoimmune disease, or they recently took some medication that's affecting the parathyroid glands, like the new immunotherapy for cancer. Or it might be a very rare disorder called autosomal dominant hypocalcemia, in which there is also elevated phosphate. So for the management of the low calcium, we follow the general rule. If there is acute, severe symptomatic hypocalcemia, then we have to be actively treating with the aggressive measures to prevent further complication like laryngospasm, severe bronchospasm, seizure. So our approach is to use IV calcium right away. And there's two main formulations for IV calcium. There's IV calcium gluconate, which is more preferred because it's less likely to cause tissue necrosis if extravasated, or the calcium chloride. But the calcium chloride has more like elemental calcium. So if we talk about one ampoule of 10% calcium gluconate, it's gonna contain 90 milligram elemental calcium. And technically, we are trying to correct the calcium by giving 0.5 to 1.5 milligram per kilogram per hour. And we can use this by adding the calcium gluconate into dextrose 5 solution and make the calculation. Then if we are talking about mild or asymptomatic hypocalcemia, then first step is to correct hypomagnesemia and hyperphosphatemia, so the calcium can correct on its own. And also another important thing here, even when it's severe, you have still to correct hypomagnesemia because it's very important for the calcium on the long run after you stabilize your patient. Other treatment also, you can give oral vitamin D and calcium. Calcitriol, which is the 125, is the most preferred. It has a fast response, and you give it with calcium. Also, if you have a liver disease, then you can give calcidiol, which is a 25 vitamin D, because the 25 step is in the liver. The goal is low normal calcium, like 8 to 8.5. Still, you can use sometimes the recombinant PTH and the ADH, the autosomal dominant hypocalcemia. Thank you for watching our video. Please, if you like the content, subscribe to our channel for more interesting videos.